right, good afternoon, everyone. I'm Pam Andrus, and I want to welcome you all to one of our Complete RX Knowledge Series events. So the goal of this series is to share news, information, and best practices for hospital and health system leaders. Today's program is going to focus on the many ways your pharmacy department can and should be positively impacting each stage of the revenue cycle. All participants will be on mute, but we encourage you all to submit your questions using the Q&A feature on your screen. And there's also going to be a couple of poll questions throughout the panel discussion, and we would really appreciate everyone's participation with those as well. I'm now going to introduce our speaker panel. Dana Fox is the Program Development Manager for Complete RX. Dana oversees the enhancement and optimization of operational processes and the launch of new pharmacy-led initiatives. Justin Sotomayor is Director of Pharmacy Informatics, and in his role, Justin supports health systems to optimize their information systems, enhance billing capabilities, and implement new hardware and software technologies. Now, both of our speakers are pharmacists, and they have over 15 years of hospital experience, so they're uniquely qualified to discuss those real-world challenges and opportunities for revenue cycle enhancement. I'll go ahead and cover the objectives of our discussion today. First, we're going to outline the critical stages of the hospital revenue cycle. We'll then move into reviewing best practices for revenue cycle management, and then the identification of new pharmacy-led revenue streams. And with that introduction, I'm going to turn it over to Dana Fox.
Thank you, Pam. First, let me get started by explaining some of the current challenges that we see within the revenue cycle. The regulatory area is one area that is rolled out annually with some changes. CMS will drop coding and billing changes in January of every year. Additionally, there are market changes going on in the drug market on a daily basis. Drugs change frequently in how they are supplied and packaged. This is another area you need to be cognizant of. Additionally, payer practices change regularly within your institutions. Drug schedules, payment lists throughout the year are changing depending on who your insurance providers are and how you're contracting with them. These need to be monitored and reviewed prior to doing any changes within your revenue cycle. Finally, technology is another area that impacts your pharmacy revenue cycle. Automated dispensing cabinets, electronic medication records, and computer systems all work together through interfaces and exchanging data throughout your health system. These require daily reconciliation and also monitoring to make sure that the data is flowing freely throughout your institution.
Okay, so having discussed those challenges, we're going to go ahead and launch our first poll question. And the question is, what is your biggest revenue cycle challenge today? Is it A, regulations and market changes, B, payer practices, or C, technology? And we'll give you just about 10 seconds to complete that poll. All right, we'll go ahead and close out the poll. And we see that 50% said technology, which is probably not at all surprising to this group because there have been so many technology changes and implementations here. And we're going to cover the revenue cycle next, but you have to understand the vastness of how large that cycle is and how many people are touching that. So I'll let Dana cover that next.
Thank you, Pam. As you can see in front of you, we have a depiction of the hospital revenue cycle. It initiates with the patient registration. This is the intake process where the patient will come into your health system or hospital, where you verify some patient information and also get the insurance cards and information pertinent to the visit. Next, you move on to the patient exam and treatment. This is the area where they visit a clinician, treatment is written, or the review of the patient to then bring them into other parts of the health system. Next, we're moving on. You see pharmacy formulary and purchasing. This is the management and upkeep of your pharmacy library, if you will, where you hold your information as well as where you purchase your pharmaceuticals. Moving on, you can see dispensing and transactions and informatics. This is where your information is housed and exchanged throughout your health system. It's a very key portion because things change daily and you have to keep up information. Moving on, patient billing. After the orders are completed in your transaction system, a bill is dropped, and this is a key portion because you have to have your coding and units properly in your system so you can drop a bill. Additionally, moving forward, you have patient assistance and retail. This is an area that, as the patient moves to an outpatient setting, where you can have an impact as well upon discharge and interchanging with their outpatient visits. Finally, you have in the other part of the cycle, you have payment processing. This is where you're working through the billing office and processing the appropriate records. And then AR and denial processing is where the back end, where you see any problems being worked throughout your system. If you notice throughout the revenue cycle, we have areas highlighted in green. These reference areas where pharmacy can positively impact your revenue cycle and make a difference within your institution. Now let us move forward with discussing the 5 ways pharmacy can impact the revenue cycle. There are 3 overarching themes that we will cover. 1, generating service revenue. 2, reducing costs and spend. And 3, capturing full reimbursements. Let me now move over to Justin so he can discuss the patient exam.
Thanks, Dana. For this discussion, the clinician exam is really outside of the scope of what we're going to talk about. We do understand that pharmacists can run outpatient clinics such as anticoagulation, diabetes, hypertension, pain management, vaccinations, and other NTM services. What we really want to focus is on the treatment prescribed. It's the pharmacist's specialty. It's what we went to pharmacy school for. We can provide cost-effective treatments that allow for decrease in drug spend and increase in revenue. On the inpatient side, the clinical pharmacist can participate in interdisciplinary rounds and can offer cost-effective treatment alternatives that could generate increased revenue through reimbursements. Also, they can participate in clinical protocols such as IV to PO conversions, antibiotic stewardship to reduce length of stays, renal function monitoring, and dosing as well. On the outpatient side, pharmacists get the opportunity to treat patients with over-the-counter remedies. These treatment options reduce ER visits for minor ailments, as well as avoid drug-drug interactions with prescribed medications. In addition, pharmacists can point the patients and customers to store-branded generics to drive up profit margins. Dana, can you tell us a little bit about the pharmacy formulary?
Sure, Justin. The formulary is a library within your hospital pharmacy. It's an important part of your daily activities. In the formulary, you try to control the amount of drugs that you have within your hospital system. This is very important. The maintenance that you do on a daily basis with prices, item updates throughout your system require a lot of intervention. It is important to keep these updated daily with changes with respect to NDCs, National Drug Codes, because as you receive different drugs, those change, and it's important with the billing process. Additionally, within your formulary, you need to have an aligned process with your P&T, your Pharmacy and Therapeutics Committee, so you can control the number of line items that you have. Most importantly to consider is if you have different drug classes, you can consolidate from 10 items down to 1. So restricting your formulary limits the number of line items that you have for billing and maintaining systems. Additionally, a non-formulary process is key. Identifying drugs that come into your institution that are not part of your formulary is imperative. Once these drugs are used, you need to capture information to understand the National Drug Code and other billing information so you can submit those properly and get paid for those services. This process identifies those drugs and allows you to acquire that information on the front end. Finally, bulk and specialty drugs present their own unique problems in how they are packaged and repackaged within the facility. It is important to keep those items at the forefront when you're building your formulary so you can process them appropriately when dropping a bill. Justin's going to review how Pharmacy buyers also are important in the process.
So pharmacy buyers' involvement in the purchasing and the tracking of medications is very important in the revenue cycle stream. In order to evaluate purchase inefficiencies, aligning of systems is mandatory. The pharmacy buyers use several platforms to purchase their drugs, including wholesalers, specialty pharmacy suppliers, manufacturers, and other back-ordered suppliers that provide pharmaceuticals to the companies. These buyers have to purchase drugs in multiple purchasing quantities, such as by the unit, like IVIG, by the vial, such as insulin, even by the box, which is usually unit dose meds, by the case, such as IV piggybacks, and even by the pallet, like IV fluids. In addition to the different ways that you can purchase a drug, they also can be done with multiple prices, such as WAC, GPO, and even 340B. This can get extremely costly if the buyer is not doing it right, but it can generate revenue with increased margins if done correctly. A common denominator for all the systems to compute these numbers should be established. It needs to be an apples-to-apples comparison. Also, we have to manage the data and the line items. You can't calculate how much you've made if you don't even know what you've spent. We have to know your expenses and know your purchase amounts weekly, monthly, and even annually. Have a drug budget and compare it versus your actual incurred costs. Review drug utilization versus on-hand inventory turns so revenue is not tied up on the shelves. Dispensing transactions in informatics is also important and one of my favorites. In the medication dispensing process, there needs to be staffing efficiencies. Having trained staff, low turnover, lean processes and workflows can increase these efficiencies. Other opportunities include outsourcing, like telepharmacy or pharmacy management firms. Pharmacy automation with robotics, automated dispensing cabinets, reduce workload, and actually reduce returns and credits. In addition, you can increase your dispense and your charge capture to make sure you are billing for all the medications you are dispensing. Medication storage carousels, high-speed unit dose packagers, and even high-speed labelers all help to increase the efficiency of the pharmacy. For instance, if it takes 2 minutes to fill an order and 2 minutes to deliver that order to a floor, you have 4 minutes total. At 500 orders, you're looking at 33 hours worth of work. For a technician to go put this in an automated dispensing cabinet, it could be about 8 hours. That gives you an additional 25 hours a day to work with. As far as the pharmacy drug dictionary build goes, we talked a little about dispensing units versus billing units earlier, but I'd like to delve more into it now. The dispensing units versus the billing units needs to match so you are capturing all of the revenue that is associated with the dispense on the bill. There can be limitations though. With CPOE and basic EHR platforms, sometimes these billing units are hard to set up, and we'll talk more about that later. In general, an optimization of your formulary should be done to ensure full charge capture. Bulk products, including the bulk product setup, need to be especially looked at closely. In a retail setting, when you dispense a bulk product, the whole dispense and the whole vial or tube is dispensed all at once. In an inpatient setting, you have a daily administration on a MAR. This can get tricky. There are different ways that this should be set up. Some include zero dosing, charging on administration, as well as entered differently for CPOE, but there's really not one best practice. It depends on the software and the version that will work best for your facility. Single and multi-dose vials also prove to be a little bit tricky. We are encouraging our pharmacy buyers to purchase the smallest vials and to limit the multi-dose vial use in accordance with capturing all the revenue generated from these products. Dana, can you help describe what the charge master does to help in this role?
Yes, Justin, I will. Think of your charge description master as a database. This database undergoes constant change on a daily basis. There's important information that is stored here that we need to keep in mind when we work through the revenue cycle. Billing and coding details are located here and cross over to the business office on a daily basis. Charge formulas are also housed within your CDM. These are updated on a daily or monthly basis depending on what you have coming into your system. The charge description master is also updated by a formulary service vendor, or FSV. One of the most common ones is FDB, or First Data Bank. They provide wholesale AWP, or average wholesale price, that is used in your system to price your drugs. This is updated on a monthly basis and provides NDC and pricing changes. Failure to keep up on a monthly basis can result in falling behind in your drug pricing or missing price increases or decreases. Additionally, with changes in the market, the FSV load can identify where your system may be incorrectly identifying things and items will kick out. It is important to work those when you do update your formulary, your CDM on a monthly basis. Finally, I want to highlight 3 drugs here. The first, Daraprim, Vasostrict, and EpiPen. These are all high-cost drugs that you may have read about in the last 3 years. They've had significant price changes that have impacted the market. What's key about these is the price change. If you did not keep up your CDM, you could be spending more on the drug than what you are getting reimbursed. So it is imperative to keep your CDM up to date with updates. One I'll highlight is EpiPen. In May of 2011, the drug cost $164. In May of 2016, when we all started to see it in the news, it cost $608. You can see the marked increase that happened throughout that time. If you were doing your drug price increases on a quarterly basis, you would have missed increases on this drug and fallen behind in your pricing. A more current drug to consider with price increases that may be impacting your institution currently or in the upcoming months is insulin. This drug, in recent stories, has shown an increase of 400% and is used daily in a large population within your institution. We have also discussed these same topics in a previous webinar within our knowledge series if you want to look at high-cost drugs and how they impact the market. Justin, can you share more information about patient billing and how that impacts the cycle?
Absolutely. So one of the areas that we're going to talk about now is the healthcare Common Procedure Coding System, also known as HCPCS. The HCPCS has a J-code plus modifiers that are linked with medications. The reason they call them J-codes is because the code begins with a J. There are multiple coded items that Medicare uses that have different letters. Medications usually start with an A or J. These J-codes are used to bill Medicare Part B for injectables and specialty drugs. Having missing or wrong codes or multipliers leads to less reimbursement. We're going to use an example of Unison or ampicillin and sulbactam. It has a J-code of J0295 with a billing unit of 1.5 grams. In the fourth quarter of 2016 payment allowance that were just released in September, it has a billing chargeable unit of $3.69. So for a 3-gram vial, it would be $7.39 payment allowance. If you did not have your multiplier set to 2 for a 3-gram dose, you would be missing out on $3.69 worth every single time the drug was dispensed. Doing some quick math, at 3 doses per day on a patient, over 365 days a year, it would equal $4,040.55 per day of each patient treated. So if you just had 5 patients in the entire year on this medication every day, you're talking $20,000 in lost revenue. Not only in inpatient, we can see results like this, but outpatient areas as well can help generate revenue. Dana, how can outpatient and retail help generate revenue for facilities?
Justin, I'll highlight a few points here. We're going to review patient assistance, specialty pharmacy, and retail pharmacy. Starting off, patient assistance programs are offered by pharmaceutical companies. This is one way for you to service uninsured patients and also replace those drugs that they use at no cost, reducing the revenue cycle impact for lack of payment for uninsured patients. One thing to consider when doing this is setting up your program to have it follow through your revenue cycle to back out any charges within your system. The patient assistance program can be budget neutral, revenue neutral from that standpoint, and can assist your facility. Additionally, specialty pharmacies are an opportunity for you to increase your revenue. If you manage specific disease states or have physicians practicing in certain subsets or practices, this may be an opportunity for your institution to expand services within your pharmacy business line. Servicing these populations can provide unique opportunities through a specialty pharmacy to manage those patients through clinical monitoring and providing drug services, both on the inpatient and outpatient arenas. A thorough assessment of your population is important to understand if this is an option that you should take advantage of in your institution. Finally, retail pharmacy is another solution that can increase your pharmacy revenues. Outpatient retail services can be aligned with your inpatient pharmacy to meet patients at that discharge when they have a lot going on. You can get prescriptions filled within your institution and have them filled and ready to go when the patient leaves the institution. Additionally, you can follow up with those customers to see if they would be interested in refills and increasing your prescription volume. This can be helpful for them because you keep them within the same network and have a medication list that helps with your inpatients for medication reconciliation. Additionally, you can work with your clinics on visits to fill prescriptions for patients when they are on site getting services. This is another way to align patients within your network and also have an additional value-added service within your institution. Finally, you can also administer vaccinations through your retail pharmacy. Pharmacists can get trained to administer vaccinations and document them for the patients within your health system. This is one area where you can compete against current big box market retailers that are providing the same service and keep patients within your network.
All right, so thank you, Justin. We really appreciate your participation, as well as Dana and all the insights that have been shared. We're going to close it out with a quick poll question. Which initiative of everything that we've discussed would benefit your health system the most? And A being clinical, B being pharmacy purchasing, C informatics/technology, D patient billing or CDM, or E retail and patient assistance programs. Just give it about 10 seconds here before we close out the poll. All right, we'll go ahead and close it. And if you take a look at the results here, we've got really most people going back to informatics and technology. And again, just pointing out that there's no silver bullet here. There's no one specific best practice because of the differences, obviously, in hospital information technology and hospital information systems. And even if you're on the same system, oftentimes there's different versions of that. So just continuing to really focus on the processes and the training associated with those processes to maximize your revenue. So before our panel gets started answering questions, we just want to thank all of the participants that were on the call today. We want to mention here too that there's a link to the recorded webinar that's going to be emailed out to all attendees for you guys to view at your convenience. And for more information on CompleteRx, along with additional articles, white papers, webinars, and events, we encourage you to visit the CompleteRx.com website. So we're going to go ahead and pull up a couple of questions here because we do have some that are outstanding. And let's see, we'll get started with, for our panel, you discussed those CDM updates. So what team members really need to be involved in this process? Who wants to take that?
I'll start.
Okay.
A couple key members that need to be involved in the CDM update is your pharmaceutical buyer, the technician or pharmacist who's involved in the purchasing process is key. Additionally, your pharmacy informatics personnel who maintain your CDM need to be involved as well. So you're identifying those drugs when they come into the institution and sharing that over to the informatics pharmacist. And additionally, you need to work with your billing department, whoever your analyst is over there, so your system matches from a description standpoint, so your coding and billing matches on both your CDM side and your billing side. Justin, any others to add?
No, I would definitely agree. You know, having that connection with the informatics, the buyer, and your accounts receivable or billing department to make sure that everything is aligned with definitely even the J codes and the multipliers and the WAC pricing versus GPO pricing, and having all that information available and put in the system will guarantee that you will get the maximum return for your billing charge.
Okay, so our next question, we talked a lot about maximizing revenue, and so the question is, what revenue increases have you seen by implementing some of these initiatives? That's a great question.
I'll take that one. So we've been working recently on several facilities that are going through these changes, and it really depends on the size of facility. Smaller facilities, 50 bed or less, can have a 5 to 6 figure increase in revenue capture if done correctly. These large facilities with either oncology or infusion centers, not capturing the revenue, not having the right J codes for CMS and other areas, we've calculated 7-figure revenue increases easily.
Wow.
So it's definitely important to monitor to make sure it's being done right. It can make a big impact to your bottom line. What do you think, Dana?
I agree with that. One other consideration to think of in your business enterprise is also the time spent if you have to rebill, and billers are having to work within your system, both pharmacy and the business office. So not only are you capturing revenue, but if done incorrectly, you're spending a lot of time on that as well.
That's a good point. So you mentioned, Justin, I think in one of the earlier slides about upcoming regulatory updates. So what should our audience be considering when they're looking at that for their own hospitals?
Yep. So CMS released a ruling on a JW modifier. It was supposed to begin in July of 2016. It's actually been moved out to January 1st of 2017. And what this is, it's a modifier to the J-coded drug items that requires documentation of the amount of drug that's wasted from single-dose vials if the whole vial is not used. And this documentation of the amount of waste of drug needs to be on the patient medical record in addition to the bill. So several EHR platforms have struggled with getting this to be documented on the patient's medical record, but they are finally coming up with creative ways to meet this regulation. So if you haven't looked into making sure that this JW modifier is built in with your current EHR billing system for the pharmacy, it's definitely something to look into.
All right, anything else to add to that, Dana?
No, Justin gave a very good overview of what's coming.
Okay. All right, well, we're right at our time limit, so we're going to go ahead and end today's discussion, but I want to thank our panel again and all of our participants, and everyone have a wonderful afternoon. Thank you.